Thank you for inviting me. It's really a pleasure to be here. It's my first time coming out, giving a talk with Innovasis. Thank you very much for inviting. And also, to credit to Dr. Bervin, he was my attending when I was a fellow at UCSF. We've done a lot of deformities, so a lot of these concepts are what I learned from his training 15 years ago. Got to tell you, at that time, 15 years ago, we didn't do lateral. In fact, we took care of a few patients who had a complication from the early adopters. And so, when I start my own practice and working with, Arashi Mami, some of my colleagues, and we had some hesitation about deformity corrections using these lateral approaches, but we realized this is a really important tool, and we're happy to discuss some of my findings. I try to limit my talk to 10 minutes, so some of the slides actually disappeared. That includes my disclosure. Unfortunately, I'm sorry about that, but I do some consultation with Stryker, but I don't own any stocks or anything like that. So the goal of deformity correction, as we know, it's really the stuff that we just talked about, restoring a sagittal coronal balance. But at the end of the day, we want to have the patient happy, relieve their pain, and we want to have a long-term good results. We tell our residents all the time, what ruins the good surgery is really, good long-term follow-up. So you want to have a good arthrodesis, and you want to have a good sagittal balance and good coronal balance, so the patient doesn't come back, 2-3 years later with adjacent segment degenerative changes. Things like posteriorly based osteotomies, we do Smith-Peterson, pedicle subtraction osteotomies. Those are great surgeries, but it's a hard surgery for the surgeons and especially for the patients to go through. It's a lot of blood loss. It's a pretty difficult surgery. Sometimes it's necessary, but if you can reduce the, some of the complications related to those things, I think it's a good thing to discuss. So potential advantage of the lateral interbody. It's really, doing the surgery the way we do the same way, but a little bit of less invasive way. We still want to achieve the good lordosis. We want to release the anterior column, anterior releases, so we can correct the deformity, and also make sure that we have successful fusion. So I'm not going to dwell on too many of the articles. I want to go over some of the other stuff. But this study basically shows that the coronal corrections from the lateral interbody is outstanding. And this little busy table shows that you can correct both globally and focal deformities quite easily by doing this lateral interbody fusion. This sagittal deformity can be a little bit of a challenge. That's something that we always know. So this another study, it's kind of a busy slide, but basically it says that you could use, by using a lateral interbody and posterior fusion, you can do significant corrections, but without too much complications. So it's another study here, so basically showing that the lateral interbody can be used to correct the spinal deformity. So I just wanted to go through those papers real quickly. So one of the main reasons I like to do the lateral interbody is really a correction of the coronal deformity. And that's why I start doing these cases. One of my first cases that I done was 80-year-old lady who has focal coronal deformity. All she wanted to do is make sure that her husband, she'll be able to go home and take care of her husband who's essentially dying from cancer. So we were able to do small surgeries and send her home, and I realized how powerful this surgery it can be. It's unique at that it can really correct the deformity, especially coronal deformity, very well. So I have 3 cases that I'm going to present to you guys. So, you guys are probably experts in all these lateral interbody fusions, but I'd like you to focus on coronal deformity when you think about spinal deformity. So if there's one take-home message from my talk is that when you're looking at the spine, especially deformity, it's not just a sagittal. You have to really understand, at least think about the coronal deformity. So, and then the first case, this particular patient is a 57-year-old woman with degenerative lumbar scoliosis. Obviously, the patient has sagittal imbalance, but coronally, overall, the patient is pretty well balanced. So there's concept of this coronal balance distance. If if you draw a center-sacral line, it bisects right through the C7. Within 3 centimeters is the number that they talked about. The patient is obviously significantly sagittal decompensated, over 12 centimeters, positive sagittal balance. This particular patient, lumbar pelvic incidence and lumbar lordosis mismatch is about 20 degrees, but it's really a degenerating process. The patient leaning forward, patient is having degenerative lumbar curvature. So this particular patient, I wanted to restore the sagittal balance. So I did a combination of the A-lift and lateral to restore the sagittal alignment, as well as to help her fuse the lower segments which are difficult to fuse. So I don't just do lateral. I do anteriors, I do posteriors. I try to do the surgery that really fits the particular patient.
But in this case, were you doing A-lift at 4-5 because of the higher complication at the next level?
So not higher complications, but for me, I thought that the patient needs L5-S1 and L4-5. So I can do both of them very easily from the anterior, but it's much more complicated on a patient who has got a significant spinal deformity to do 4 levels or 3 levels anteriorly. Go ahead.
Did you reposition the patient in between your A-lift and the lateral?
Yeah, so these are usually done staged manner. So I prefer to do, if I was really good at oblique, I may be able to do L3 to S1 in the same position, but I don't really do obliques. I'm not just good at it.
Yeah, with
so,
Innovasis, I'm trying out the single position A-lifts.
Yeah.
So you actually do an A-lift from a lateral position.
Yeah, yeah.
And I've had good success with it. It's a little finicky because how you're standing and your view of the patient is completely different, right? It's almost like you have to sit down and you're working straight ahead.
Yeah.
But I think it saves you a lot of time versus reconfiguring the patient.
You're absolutely right. Those kinds of advances and doing all these approaches to anterior, that's going to save the patients a lot of time in the operating room, and also it makes the surgery much more. Yeah. 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 It's, some of that is work in progress. So this particular patient, if I remember correctly, we've done A-lift first and then the lateral, just because the vascular surgeons are always available at 7:30. So they like to get these things going. And then we stage the patient. And we bring the patient back a few days later, a week later, and then get us, during that time, we have the patient mobilize, have them walk, and then do the posterior surgeries. And these are done open surgeries. This is not like, with the MIS surgeries to try to percutaneously. Again, there's some guys doing that kind of surgery out there. In my experience, just this is what I was told to do. This is what I'd like to do.
A lot of times I feel like the ideal operation is to do, because adult degen scoliosis, 2, 3, 3, 4 lateral, and you always want an A-lift at 5-1 at least.
Yeah, yeah.
Then I always have to kind of think about incisions.
Yeah. I think that's it. Yeah.
So I try to either don't do a lateral, sometimes I'll T with 5-1.
Yeah. Yeah.
We're going to get into this afternoon a little bit, but I think one of the major compromises we see with minimally invasive surgery is 4-1, and especially doing T-lifts or axial-lifts or something like that at 5-1. Our distribution lordosis is really important in these cases. Again, we'll get into this with Mike tomorrow, I believe, on deformity. But the point being that we really want most of our lordosis, 2/3 of it, from 4-1. And that's where I really don't like to compromise. I do that best with an A-lift, right? An A-lift, by definition, I'm doing an AL resection, I'm getting my most lordosis, I'm using position. And oftentimes, let's look at it this afternoon with the MIS. What I'm seeing is a compromise in what's happening 4-1 with a lot of MIS techniques.
Well, and also you're doing lateral at 4-5. I mean, the vast majority
Yeah, I totally agree. But I do think that, although the patient is globally well balanced, the locally, she has a quite significant degenerative changes. And oftentimes, try to correct it from just posteriorly doing osteotomies. It's a bigger surgery. And yes, you're definitely right, they increase the cost, but by releasing anteriorly, the patient's spine moves much more easier. It's much easier surgery. You don't struggle with putting the rods, and you don't need to use those Innovasis, those Vandamies, try to correct. It's just much more easier surgery in my hands. And to correct the deformity, end of the day, I would like to walk away with the good-looking X-rays too. So personally, that's what I like to do. But I do think that this helps us to correct the deformity the way I want to fix the spine. And I think a lot of this rotational deformity that you see, it's also, yes, we like the lumbar lordosis, majority of them from 4551, but there are some advantage of correcting that focal segment 2334 as well. So, okay.
When you do that XLIF
Yeah.
spine, do you release the ALL?
Not these kind of cases. If the patient has a significant kyphosis or flat back that's coming from the focal 2-3 or 3-4, and I'm thinking about maybe doing PSO if I wasn't releasing it, sometimes. But honestly, I don't think most people do that anymore. I think just by doing multiple levels properly, oftentimes it's correctable. But if the patient has significant kyphosis or significant focal lordosis that needs to be corrected at that segment, sometimes we do, yeah.
So it's a little worried vacuum here, but the kyphosis looks like it's upper lumbar spine. They're not releasing the ALL. What is it?
Well, it's releasing the lateral ligaments, and it does correct the scoliotic deformities, the coronal deformities. And a lot of times, by using the anterior column support, you can compress from the posteriorly and correct that deformity, as you can see on these X-rays. And you can see that by just releasing, and it gives you lordosis back to it. And when you try to instrument from the back, just by compression and positioning the patient, it does compress us down. So. Yeah. So yeah, I'm just going to go through real quickly. So the reason I wanted to show these three cases is because the second case, this patient is leading to the concavity of it. So it's again, this is not globally balanced and coronally. So this is something that we should again think about it. So I did the same kind of procedure. This is much more fixed, rigid spine. So again, 55 degrees. But this is a different kind of patient. This particular patient I didn't do the ALEF on, but so the advantage of these the lateral is that the patient's outcome and post-operative care is more predictable than doing a PSO. So I'm just going to go through real quickly so we can be on time. So third case, again, I'd like you to just kind of think about the global coronal imbalance. This is a type C. This is basically the patient's leaning to the convexity of the spine. So it's a little bit of different animal. This is a little more challenging in terms of long-term outcomes. Again, this you can see that the patient is decompensated to the left. These are some of the perimeters. So we do some preoperative planning, and you can do those releases at the apex of the curvature and stabilize a spine relatively less invasive way, but still requiring posterior in my hands. So.